My name is Rajay Narain. I'm one of the research fellows of CRI based at St. George's University Hospital. So as my presentation says, I'm going to talk about a pragmatic approach to screening with special emphasis on what CRI does and CRI's experience. So my talk will basically a quick introduction of what we know so far about screening, recommendations which are out there about screening, and CRI's program, CRI research program and screening program. And obviously we will try and quickly present about the population screening follow-up data from year 2012. So as we all know that the main aim of screening these young people is to prevent sudden death, which are mainly because of inherited heart conditions, most of which can be picked up during life. And many of the sporting bodies and the scientific bodies, they recommend that pre-participation screening should be done to prevent these deaths. But we also know that many of these deaths are likely to happen in non-competitive athletes. So what do we know so far? We know so far that it is more common in males than in females. It has been reported more in basketball and football players, and it is more common in black athletes, and many of these deaths have occurred just after exercise. Obviously, we have all, I'm sure most of us already know about all these important causes, but just a quick reminder about the structural and electrical causes of sudden death, which we look for when we are trying to screen these people. So many of the sporting bodies in the UK Athletics, the Rugby Union, English Institute of Sports, the FA, the British Lawn Tennis Association, they all are very proactive and they try and get their players screened on a regular basis. This is what they do. The ASC European Common Protocol of doing a personal physical examination and looking at the cardiovascular disease in the family, and physical examination with a 12-lead, including 12-lead ECG, and obviously deciding on what they find on the ECG, they decide about their further eligibility for playing. So obviously all those problems which are highlighted in the red box are definitely a no-no as far as competitive sports are concerned. There is ongoing debate, as we all know, that there is always question about the cost effectiveness of this screening. There's always false positive, false negative. The psychological impact screening has on these players, especially if they are doing sports at an elite level, and there are medical and legal implications to it. But amongst the discussion and amongst the debates going around, there is one organization which has been tirelessly working for over a decade, whether it be Scotland, Ireland, Wales. Cardiac Risk in the Young has been working tirelessly for over a decade, screening hundreds and thousands of these young people and preventing several of these deaths. Cardiac Risk in the Young works and runs a lot of programs, including family screening programs, school screening programs, sports screening programs, screening up to 12,000 people each year. Its most popular screening program is the family screening program, which is a national screening program, screening people between 14 and 35 years of age with a trained ECG physiologist, and they get an echo on site if they have abnormal ECG, followed by consultation with a cardiologist. And obviously, people who have got abnormal ECG or echo, they get referred to the local hospital for further tests. As most of these family screenings are funded by the families, so it is completely free for people who turn up for this screening on the day. So people who have registered at least we see about 100, 125 people in a day, they don't pay even a penny to get screened because this has been funded by the family. Apart from doing research, apart from doing screening, CRI has also been heavily involved in doing research and very supportive. It gets and tries and gets one of the best talents from across the country, all young budding cardiologists who are there out in the country doing, to be part of their CRI's research program, CRI's screening program. And because of these CRI's research program, we are now learning more about population screening. We have been able to differentiate between black and white athletes and difference between athletes are DCM and HOCM. We are learning now more about young footballers' heart. We, for the first time, know more about veteran athletes' heart. And one of the most common ethnic group in the UK, which is the South Asians, for the first time we are looking into the sudden cardiac death incidents in South Asians. CRI also runs a very fast-track expert cardiac pathology service, which is a center for excellence, with a turnaround period of 2 weeks. So most of the results are available within 2 weeks of receiving the samples. CRI also runs a very compassionate, very caring, and very supportive bereavement service for families of bereaved. Most of these are to support the family members of the bereaved. CRI has got a network of volunteers who have suffered sudden death themselves in the family, and many of these are accredited by the British Association of Counselling. It also runs many support days which are led by our fellows, our doctors, to support the families and give them more information about their problem. So with that background, I'm going to present to you the follow-up data of CRY from the year 2012. So in the year 2012, we screened about 12,000 people aged between 14 and 35, which costed about £35 per person to screen. They all underwent a health questionnaire, an ECG, an echo, and a consultation with a cardiologist if they had abnormal ECG. And I'm happy to say that this follow-up data was presented at EuroPrevent earlier this year and was declared as face of the EuroPrevent conference. So out of those 12,000 people who were screened, we found that about 9.4% of those, they needed an echocardiogram on the day because they had abnormal ECG. But the good thing was that out of those 10%, about 6% were clear on the day, and they did not need any further investigation. So the remaining 3.4% were referred to the hospital for further tests because they had family history of SADS, or they had T-wave inversion, or had signs of accessory pathway, or had symptoms of palpitation, chest pain, or shortness of breath, or were found to have valvular lesion on their echocardiogram. So we wanted to follow these people as to what happened when they went to the hospital. But it was a big task because they were all across the country. So we took help of modern technology and did an online survey. And we contacted these people through email, through postal letters. And about 70% of these people, they responded. And they said that they underwent further investigation at the local hospital with a Holter, with an exercise tolerance test, with a repeat echocardiogram, and some also had a cardiac MRI done. And we found that out of those 231 people who responded to this survey, 31 people had already been given some kind of cardiac diagnosis. So out of those 12,000 screened in 2012, 0.25% had already had a cardiac diagnosis, and another 0.1% were undergoing more tests. But the most interesting thing was that majority of these diagnoses, about 60% of these diagnoses were picked up on the day of the screening. Only 40% of the people needed more tests at their local hospital to confirm the diagnosis or to investigate them in more detail. So these were the most important diagnoses which were picked up on the day: WPW, DCM, heart blocks, some valvular heart diseases. And on subsequent hospital visit, they were also found to have, some of them were found to have ARVC, HOCM, more heart blocks, CPVT. Out of those 9 heart blocks that we see on the screen, about 2 of them, they needed pacemaker. So this only goes to prove our point that it is worth screening the young people, because sudden cardiac death in young is very visible, emotional, and it affects the young. It is easily identifiable and with minimal intervention. Our Italian colleagues have proved that screening works and helps in reducing these incidents. So in conclusion, ladies and gentlemen, large-scale population-based screening program based on the ESC guidelines is extremely feasible, and our low referral rate indicates that it can be done with relatively low additional cost and investigation burden to the NHS, because every life saved matters. Thank you.